This clinical toxicology video discussion is about dextrose, which is the D-stereoisomer of glucose that's most important in biological systems. Like, if we're talking about giving a patient glucose or what their glucose level is, that's the same thing as dextrose. This topic corresponds to Antidotes in Depth Chapter A8 in Goldfrank's Toxicologic Emergencies. This topic and this chapter are pretty straightforward. Indeed, you could almost say that it's unnecessary. So there's only one learning objective, which is to be able to identify at least 3 toxicologic indications for administering dextrose, which is to say, provide at least 3 different toxic exposures, at least 3 different substances, where you may want to use dextrose. It's not going to count if you just say hypoglycemia. Obviously, dextrose is an immediate antidote for drug or toxin-induced hypoglycemia. The patient's glucose is low, so you give the patient some glucose. The particular figure here defines hypoglycemia as a serum glucose less than 70 mg per deciliter, although the Goldfrank chapter defines it as 60 mg per deciliter or lower. But it's not the absolute number that's important, but whether the patient is showing clinical effects along with a relatively low serum glucose. That's a better practical definition of hypoglycemia. On the right, we see a list of various signs and symptoms that may be seen, and I'll additionally note that most of the ones near the top relate to a patient's sympathetic nervous system response to hypoglycemia, which may cause tremor, sweating, tachycardia, or a sensation of palpitations. Whereas those near the bottom of the list are caused by neuroglycopenia, by low CNS glucose, including seizures and coma in the most severe cases. In clinical toxicology, we may see all sorts of patients with altered mental status or coma, and we need to remember that hypoglycemia is one of the few causes here that are rapidly reversible. A patient with opioid toxicity could be treated right away with naloxone, a severely hypoxic patient can be cured with oxygen, and an altered patient with hypoglycemia can recover right away if given glucose. Some sources talk about a coma cocktail, where unresponsive patients are given all 3, naloxone, oxygen, and dextrose, because you might get a great response, and these treatments carry minimal, if any, risk. Therefore, all patients with altered mental status should either have rapid glucose testing to check for or to rule out hypoglycemia. This is typically done by fingerstick blood glucose test strips and glucometers. Or if such rapid bedside testing is not available, giving dextrose empirically just in case the patient is hypoglycemic. The most common way to give dextrose in such situations, either in the EMS pre-hospital setting or in an acute care setting like the emergency department, is to give an amp of D50, which is to say, 1 ampule of 50% dextrose solution. These ampules are 50 milliliters, and the concentration of 50% means there are 50 grams per deciliter, or 50 grams per 100 milliliters. If there's 50 milliliters, that means each amp contains 25 grams of dextrose, which is about 85 kilocalories. For reference, a typical candy bar like the Snickers contains 250 calories, so each amp of D50 is about 1/3 of a Snickers bar, and we'd expect each amp to raise the serum glucose by about 60 milligrams per deciliter for a general frame of reference. The chapter references a few different sources, and the range of serum glucose elevation after an amp of D50 can vary considerably. Of course, a major use of dextrose among tox patients is to treat hypoglycemia resulting from overdose of medications to treat diabetes mellitus. Insulin toxicity happens quite a lot, and a typical history is that a patient with insulin-dependent diabetes takes their insulin, but either forgets to eat or maybe they're having nausea and vomiting and can't eat, then sometime later they get dizzy and sweaty and maybe pass out or have a seizure. This is pretty straightforward to treat. You give dextrose IV for emergent presentations, get some oral calories into the patient, observe for recurrence of hypoglycemia versus recovery, and nearly all of these patients can be discharged home. On the right side of this slide, there's a figure of a sulfonylurea, a very common oral hypoglycemic drug class. And this is here to represent more drug classes than just the sulfonylureas, although they remain a major source of drug-induced hypoglycemia cases encountered clinically. These non-insulin cases of hypoglycemia can be more complex to assess and manage, and we'll discuss this more in another video about toxicity from drugs used to treat diabetes. Some other uses for dextrose in tox patients include high-dose insulin euglycemia therapy, which may be used to treat severe cardiovascular drug toxicity and discussed in other videos in this series. Here the dextrose is playing 2 roles. One, to prevent hypoglycemia, and the other serving as a source of energy that the high-dose insulin is helping to get into the cells. Salicylate toxic patients have a relative neuroglycopenia. That is, the CNS glucose levels are lower than found in the serum. So even if the patient has a reasonable serum glucose level at the lower end of normal, some altered mental status might be corrected if we raised it a bit more. Dextrose has an obvious use to treat hypoglycemia induced by exposure to ethanol. This is something that pediatric patients are at higher risk to develop than adults. A child with a hopefully unintentional exposure to ethanol can have altered mental status from the ethanol or from associated hypoglycemia. And glucose plays a key metabolic role in treating alcoholic ketoacidosis. Dextrose is remarkably safe and rarely causes any complications, but what complications could occur? The biggest complication is not exactly an adverse effect of dextrose, but in failing to give it. If you don't think of hypoglycemia, don't diagnose it, and don't treat it, well, that's not good for the patient. D50 is very concentrated and hypertonic compared to the plasma. It's like a thin syrup, and you have to push pretty hard to get it through an IV quickly. And this is fine if it's only used occasionally as an emergency dose through a peripheral IV, but the high concentration can damage the blood vessels. So if you need to give repeated or prolonged dextrose, it should be given through a central IV line, where it'll get diluted faster and be less likely to cause phlebitis or vein sclerosis. Also, when treating hypoglycemia from sulfonylureas, each time more dextrose is given, the pancreatic beta islet cells detect that increase in glucose and are induced to release even more insulin, potentially causing a rebound hypoglycemia. Now, that would just be treated with even more dextrose, but there's the sense of chasing your own tail, and octreotide, discussed in other videos, might be a more elegant approach in such situations. And lastly, there is a persistent medical myth about not wanting to treat patients empirically with dextrose if they are not given thiamine first, to avoid inducing Wernicke encephalopathy from the glucose load. While this is a theoretic risk and has occurred in some case reports, that risk is very low, it's not mitigated by acutely giving one dose of thiamine first, and it's a greater risk to leave the patient hypoglycemic in the meantime. Well, that seemed to be plenty of words basically saying if the glucose is too low, you should give some glucose. I'll be seeing you around.